I went to the ASA in Philadelphia last year, and I was giving a lecture, and right nearby, Dr. Maxey-Jones was giving a lecture along with a friend of mine, Andy Shaw, who's moved around from Duke to maybe Vanderbilt to Alberta and now in industry. But anyway, a fantastic lecture by the both of them. And I thought, wow, this is someone I would like to hear. We try to have great speakers, but both knowledgeable and people who can impart information. So we're going to introduce Dr. Maxey-Jones in just a minute. But before I do that, we're going to do a little brief commercial about what we do in Grand Cayman, and hopefully we can entice you to come join us. So again, we have a meeting at the end of January, January 26, 27. You can find more information at destinationcme.com. We'll have a postcard going out. It'll be 26 hours. Probably we don't have AANA credit yet, but that'll probably be 26 also. That's from last year, 24 and 26. So this is just a preliminary. You'll get a postcard like this in the mail. And just to go through some of the faculty that we have coming. Before we do that, we have fun, as you can see on the left. But on the right, we do have education. But we also, one of the things that's really nice, as you can see on the bottom right there, is that folks are learning from each other. So we try to have a social environment where people can say things like, yeah, they do that at the Mayo Clinic, but I'm in a group of 20 people. How do we do what they do at the big house? And I think people really learn from each other, come back year after year, and people make friendships. So I'm the course director. I have faculty appointments at Penn and University of Miami. I no longer practice, but love education and continue doing this stuff. My former colleague, Bobby Jean Schweitzer, is coming down. She was one of the co-authors of the most recent AHA-ACC guidelines on non-cardiac surgery, perioperative management. Also talks about anemia and ambulatory anesthesia. Josh Zimmerman came to us before from Utah talking about ultrasound. Mike Fitzsimons, who helped train Dr. Maxey-Jones, zoomed in for us last year, but he'll be in person. He was supposed to come for us during COVID, but things got pushed ahead there. He's going to talk about early CT ICU care as well as some wellness issues. Andy Leibowitz is the chair of anesthesia at Mount Sinai in New York, and he's going to talk about leadership and fluid therapy and intubation outside of the OR. Anushka Alfonso is at Sloan Kettering, and she's going to talk about anesthesia for patients with cancer and some of the really innovative things that they're doing there with ERAS at Memorial Sloan Kettering. Dan Katz, young dynamo, doing work on simulation, runs the Sim Center at Mount Sinai. The Mount Sinai people have taken over, but that's a good thing. They're good people there. So he's going to be talking about simulation. And then we have a few faculty zooming in. One of the reasons we do it is because they're actually bigger on the screen than they are someone standing at the podium. And it lets us get a lot of people to give one-off lectures about, they can give their very best lecture. So Peter Slinger is going to talk about pulmonary stuff. Keith Ruskin from Chicago talking about neuro. Natalie Barnett, another Sinai alum, talking about pediatric anesthesia. And Justin Richards from Shock Trauma is going to talk about trauma. That was the best emoji I could come up with for trauma. And this is a fun thing that we do. We actually do on the second afternoon or evening going into sunset of the meeting, we do sail with the professors. This is actually 2 hours of CME credit. This is actually a drone view of our boat. We hand out cases, the faculty are on the boat, and people talk about the cases or just ask the faculty about the lectures that they've given, and everyone has a good time out at sea. So again, the end of January 2026, the end of January 2027, destinationcme.com. So let me stop sharing my screen. And what I do want to do is introduce Dr. Courtney Maxey-Jones. Let's see if I can stop sharing here. So again, I told you I heard this great lecture by her at the ASA. And I said I wanted to get her. And it's very interesting talking to her just now. I told her one of the things I took away from her lecture from a cardiac anesthesia point of view is that with mechanical assist devices, anyone can be a cardiac anesthesiologist. Now, that's an exaggeration, but it makes life easier. This lecture is going to be about the use of these devices in patients undergoing non-cardiac procedures. But the other thing I learned from her as we talked before we opened it up to everybody is that, you know, she's really had, I think, a quite interesting approach to her practice. She has an appointment in the cardiology department at SUNY Upstate in New York. By the way, she trained in anesthesia, TEE, trained at Harvard, trained at Cincinnati. She can tell you more about her background, but I just found it fascinating the way she's working now between doing cardiac anesthesia, CT ICU, and the way she's been able to fashion a role for herself. So I think I've talked long enough. By the way, we did say this in the registration email. We don't offer CME or CE credit for this. The amount of work to do that is about the same amount of work as it takes to accredit our whole course in Grand Cayman. So we hope all of you appreciate the excellent education that you're going to receive. So without further ado, Dr. Courtney Maxey-Jones, take it away.
All right, well, thank you very much, and I'm happy to be here. Virtual is nice. I'm comfortably at home. Let me just see if I can get my screen shared here. All right. Yes, so my name is Courtney Maxey-Jones. I'm cardiac anesthesia and critical care trained. I did train with Dr. Fitzsimons at Mass General and did some additional training in cardiac critical care specifically at University of Cincinnati. And then I came home to Syracuse, New York, where I worked for several years in private practice, but then decided to kind of go a different direction with things. And in the past 2 years, I've been working as, kind of an independent person with appointments in various departments at various hospitals. And what I've found is I've been able to, I think, affect the care of more patients by having a presence at multiple hospitals. As Dr. Ellis noted, I currently actually am appointed in the Department of Medicine at Upstate, where I work in the cardiac ICU. And then I spend, about half my time there, and currently about half my time is at UHS Wilson Hospital, about an hour south in Binghamton, New York. And there I kind of do everything: cardiac anesthesia, cardiac critical care, and kind of help with overall optimization of their cardiac surgery program. So when Dr. Ellis approached me about talking about something that would be, kind of an area of expertise for me, but also something that would be applicable to not just cardiac anesthesiologists or not just cardiac intensivists, and really a broader scope of not only anesthesia personnel, be it anesthesiologists, CRNAs, residents, but also just kind of an overall view of these mechanical support devices. And then, so I decided that a good topic would be, managing acute mechanical support devices for non-cardiac surgery. And then it was very fun because I figured out a way to use the poop emoji to make a subtitle. So regarding, the idea that you're going to have these patients with devices who are going to end up with other procedures that they're going to be in need of. So, just to be complete and open and honest, I'm going to use guidelines and data as is available, but there's not a ton of data and guidelines available, if I'm being totally honest, in this arena. But there are some new ones, and I'm going to highlight them here. The other thing I'll note is I'm giving this as my opinion. I'm representing only myself and my own thoughts, but I do have some industry partners that I work with, including I am an educator with the device manufacturer, the Impella, that I'm largely going to speak about today. So the outline for the talk is I'm going to discuss our current TMCS, or temporary mechanical circulatory support options. I'm then going to discuss a recent landmark paper that has recently led to a guideline change. And then I'm also going to discuss percutaneous LVADs, otherwise known as Impellas, their function and management. And I'm going to discuss the kind of must-knows for if you're going to care for an Impella for non-cardiac surgery. And then I'm going to discuss what I think might be the future state. And now I suspect a bunch of you are sitting here thinking, I know exactly what to do. But in a more real sense, I have no idea what to do if you encounter a patient with an Impella for needing perioperative care. However, I hope by the end it'll just be, I know exactly what to do. So when we talk about temporary mechanical circulatory support devices, these are devices that get put in patients, and that patient has this device and essentially lives in the ICU of a hospital. And the truth is, mostly they either live there till they get better and get rid of the device, or they unfortunately probably may not get through. That's how critical it is when these patients end up on these devices. When we talk about the temporary mechanical circulatory support options, we're talking about essentially three big categories. One is the intra-aortic balloon pump. Two, the one in the middle, the one that I'm going to focus on today, is the Impellas, the percutaneous LVADs and RVADs. And then on the right is ECMO. ECMO is our third option for temporary mechanical circulatory support. ECMO comes in a variety of different configurations and with multiple different companies producing their ECMO platforms. The similar thing is true for balloon pumps. There's multiple different companies that have balloon pump products on the market. The reason in the percutaneous VAD arena that I refer to them as Impella, Impella is a trade name. However, that is the only current device available that's in this percutaneous VAD. So at this point, percutaneous VAD and Impella are essentially synonymous. Now, the reason why I'm going to speak specifically about Impella is because of this. Because unfortunately, the other two categories, balloon pump and ECMO, don't have any proven benefit. When I'm talking about proven benefit, I'm speaking to a very specific patient population that gets these temporary mechanical circulatory support devices, and that's the cardiogenic shock patient population. In most cardiogenic shock, about 70% of it is related to an acute MI. So the studies I'm referencing here and a lot of the guidelines I'll discuss are related to that population, acute MI cardiogenic shock. These devices are also frequently seen for people with decompensated heart failure, and they're also kind of seen in people undergoing procedures in the cath lab, whether they be planned or emergent, or even as rescue scenarios when something goes awry in the cath lab, and similarly in the cardiac OR. Looking at the data for balloon pump, the landmark trial was called IABP Shock 2. What they did was they took these patients with acute MI cardiogenic shock, they randomized them to either receive standard of care or standard of care plus an intra-aortic balloon pump. Unfortunately, at the 30-day mark, there was no difference in survival if they had the balloon pump or if they did not. This study was followed up by another study where they actually followed patients for a full year. And again, there was no difference between receiving a balloon pump or not. And then similarly, the ECLIS shock trial, where they evaluated randomizing the same patient population, cardiogenic shock, to either receive ECMO or to receive, other supportive care. And unfortunately, and I'll say sad for me, I'm a big fan of ECMO and a big supporter of it, and I still think it has a role, but unfortunately, the 30-day mortality was no different. So for a long time, we essentially had nothing that we could do in terms of mechanical circulatory support that showed any benefit in terms of what matters most, surviving acute cardiogenic shock scenarios. And that's until last year. In April of 2024, published in the New England Journal of Medicine was the DanGer Shock trial, which was microaxial flow pump to support infarct-related, meaning acute MI, cardiogenic shock patients. This was a study that it did take about 10 years to finally complete the enrollment. And so, that's one of the critiques. But what it showed was a proven benefit for microaxial flow pumps. And when we say microaxial flow pump, we're talking about the Impella CP. By placing an Impella CP plus providing standard of care versus just providing standard of care alone, there was an absolute reduction in mortality of 12%. And that translates into a number needed to treat of only 8, which in medicine, anything that's a number needed to treat of a single digit number is really impressive. The other thing that's impressive with it is that they followed the patients for 180 days. So I think that's key because and I hate to say it, but as an ICU physician, I can just about keep anybody alive in an ICU for 30 days with my toys and mechanical support. So the fact that they followed the patients to 180 days really to me means it has a meaningful full benefit. So the other critiques, just to be honest about this, were, of course, some more complications in the group that got the Impella, and that's related to the device itself, large bore access, those types of things. The other critique is that there was some sponsorship from Abiomed, the device maker. However, it was at the end when they were struggling to complete due to the length of time, so they didn't actually have any role in adjudicating the trial or designing the trial. And then finally, it's just my own thing, but they called it the danger shock trial, and danger sounds bad, but it was actually good, and danger comes from Danish German. So this is very recent. This is only 1 year ago. And it's really finally kind of demonstrating something we can do with mechanical circulatory support and cardiogenic shock, because it's the first and only positive trial for mechanical circulatory support in acute cardiogenic shock patients. And so after just that study and after only 1 year that it's been out, this data has led to a guideline change. So just recently, as in earlier this month, the 2025 practice guidelines were published. That comes from all of the big sort of players: American College of Cardiology, American Heart Association, the emergency medicine folks, the EMS folks, and also SCAI, which is essentially that's Society for Coronary Angiography and Intervention, otherwise known as the cath lab guys. And this is a guideline regarding the management of acute coronary syndromes. So it's a big deal because these guidelines have, I think, were last updated about 10 years ago. So it was due for a practice update. And based on the danger shock trial, there were many changes made to update the care recommendations. However, my specific area of interest is related to mechanical circulatory support in patients with, ACS, acute coronary syndrome cardiogenic shock. And this was really impressive because for the first time, we find microaxial intravascular flow pump, or otherwise known as Impella CP, getting a 2A indication, giving it an indication to insert this pump to reduce death in selected patients with STEMI and severe or refractory cardiogenic shock. Combined with this was the placement of balloon pump and VA ECMO down at the bottom of the screen, moving it to a level 3 of evidence and recommendation, meaning that there's no benefit. And so they're recommending against routine use. Europe had already had balloon pump in the recommendation level 3, but now the US has moved there. So this combination is leading to a paradigm shift where people in bad shape with a heart attack are now going to be more apt to receive an Impella CP and probably earlier in their care. So many of you in the audience might be thinking, so what? That's nice. Hashtag cardiac anesthesia problem, academic hospital, not my problem. Well, the issue is it's time for a reality check. And so the reality check is Impellas are now present in over 1,400 hospitals in the U.S., probably closing in, it's expanding so rapidly since this new data and guideline change that it's probably up to higher, more like 1,500 at this point. However, only about 1,000 hospitals in the U.S. perform cardiac surgery. And of those, only about 150 perform heart transplants. And so this is simple math, but it turns out 25 to 30% of Impella programs are in hospitals that do not have cardiac surgery programs. And guess what? No cardiac surgery program means no cardiac anesthesiologist. So, and to be fair, even if there is a cardiac surgery program in cardiac anesthesia, they're going to be in the cardiac OR. So what this means is the general anesthesia team and any anesthesia provider, you're up to bat when it comes to taking care of these patients. The truth is, these Impellas can be placed essentially in a matter of moments in the cath lab. And because of this guideline change, I think it's going to become almost standard of care that if your hospital has a cath lab, your hospital is going to have the ability to put an Impella CP in. And this ratio of hospitals with Impellas but without cardiac surgery is probably going to slide towards even more hospitals having Impellas that don't have cardiac surgery. And so I think the key is, as an anesthesiologist, even if your specialty is not cardiac, you may need to take care of one of these patients, and it will most likely be not in a planned or routine fashion. It'll be the patient that for whatever reason needs an urgent procedure, whether they need an XLAP for bowel ischemia, or they're having an issue with their leg related to malperfusion, they're having a GI bleed and they need a colonoscopy. Either way, this is probably going to happen, and it's probably not going to be in a particularly controlled environment where you have time to plan and wait till daylight hours, those sorts of things. So with that background, hopefully I've convinced some of you that it's important for you to know about these devices. And with that, I'm going to, and also explain why I'm going to focus on Impellas in terms of the temporary mechanical circulatory support options available. So I want to really focus on the CP. So the reason I want to focus on that is that's the one that's a left-sided support that can be placed in essentially any cath lab in a matter of moments by interventional cardiologists. In terms of what the impressive things interventional cardiologists can do, placing this device is not particularly challenging compared to their routine day-to-day stenting, TAVRs, those sorts of things. So there is, just to be aware, also an Impella 5.5. It's the larger device on the left. The Impella CP is the one in the middle. And the key with the 5.5 is that does require some surgical intervention in order to place it. That's the one that's more commonly being seen in conjunction with a cardiac surgery program. So not really as applicable to this talk. And then additionally, just for awareness, there is a right-sided Impella. That's the device on the right side, and that is for univentricular right ventricular support. Again, RV failure is luckily less common. And also this RP Impella is available in less centers. All three of them have one thing in common, and that's at the bottom. That's the automated Impella controller, which I'll discuss more in a few minutes. But going forward, when I discuss Impella, I'm going to be referring to the Impella CP. So the Impella CP is, as I described, it's a small device. It is a left ventricular assist device, and it's placed percutaneously in the cath lab traditionally via the femoral artery. It's a pretty large bore access. The device itself is a 14 French, Impella device, and it's on a 9 French catheter. So it is a large access into the femoral artery. Just for comparison, a balloon pump is typically about 8 French. Traditional arterial lines you might place in the femoral artery are more like 4 and 5 French. So it is pretty large bore access. If you look at the image here, you'll note that it has a pigtail on the end. This pigtail sits into the LV cavity. Next, there's an inlet area. That's where blood will enter the Impella. Then there's essentially a bend. That bend is about where the aortic valve is going to be. This device is going to cross the aortic valve and sit in the left ventricular cavity. And then there's an outlet, and actually the motor is sitting right there. So the way this device works is Impella comes from the word impeller. It functions like an Archimedes screw, a rapid revolution leading to blood entering the device, passing through it, and then exiting above the aortic valve. As you can see in the graphic on the left, that's kind of at the pigtails down into the left ventricle cavity. Then there's the inlet, and then out, it crosses the aortic valve, and in the ascending aorta is where the outflow of the device is. So what does the device actually do? And this is why it's key, is the Impella has benefits first and foremost for the patient in cardiogenic shock, as well as benefits in terms of the heart recovering. So I always said that, the challenge is, the heart is a muscle, and an MI is like a pulled muscle, a really bad pulled muscle. But the challenge is when you have an MI that leads to cardiogenic shock, it now means your muscle is unable to pump enough blood forward to supply the metabolic needs of the body. And now it seems, simple, and I'm simplifying a little bit, but conceptually, if you're, the heart's a muscle. So if you're doing a squat and you pull your hamstring, you rest your hamstring. You don't do 100 more squats. However, when you have cardiogenic shock, we can't rest the heart or the body dies. So what do? We whip the injured heart with inotropes and things that create a worsened oxygen supply and demand mismatch because we have no other alternative. And so that's where this device comes in, is this device allows us to rest that injured muscle, rest the heart, and we don't have to worry about the body dying when the heart's not working. So what it does, again, in this image, you see the pigtail, you see the cage to the right of the screen, and that's where the blood's going to flow into the device. It's going to go through the device and then come out kind of near that red mark, and that's going to be above the aorta. At about the bend is above the aortic valve. The aortic valve will be about where the bend in the device is. So what this does is first and foremost for the body. It provides forward flow. So more flow also increases the blood pressure, and as a result, you get an improvement in your cardiac power output. Now, cardiac power output is a very specific calculation. It's the MAP times the cardiac output divided by 451, which is a constant. Don't worry about memorizing that or anything. Just remember that the cardiac power output has proven to be the single best independent predictor of survival to hospital discharge in patients having acute MI cardiogenic shock. So the Impella allows you to increase the effective cardiac output and increase the MAP, so it improves your cardiac output, improving end organ perfusion, and improving your chances of survival. Secondarily, it also helps the injured heart to recover. By providing forward flow and an increased MAP, you're going to increase myocardial perfusion, so increase the oxygen supply. We do this because we know that coronary perfusion pressure depends on the driving pressure, which is the diastolic blood pressure, and then it also depends upon the resisting pressure, which is the LVEDP. Conveniently, because this device is sucking blood out of the heart, you are also lowering the left ventricular end diastolic pressure and volume, so you're decreasing the mechanical work an injured heart has to do. This is decreasing wall tension, decreasing microvascular resistance, and again, helping to improve myocardial perfusion. Additionally, decreasing the LVEDP will decrease left atrial pressure, will decrease pulmonary congestion, remove pulmonary edema and hypoxia from being in the equation, also further increasing oxygen supply. All of these things work together to result in the outcome of that danger shock trial. The patient survives and recovers, and the heart recovers, and that's kind of the two keys. A more simplified approach to looking at the Impella CP is to call it the sump pump. Turns out it's the sump pump of the left heart. Now the key, and what I show in the picture on the bottom right, is that anatomically the heart is between the lungs. However, what's more important is physiologically, and turns out physiologic is opposite of anatomic. Turns out that while anatomically the heart is between the lungs, physiologically the lungs are between the hearts. And by that I mean the blood goes from the right ventricle through the lungs to get to the left heart. So it actually goes right heart, lungs, left heart. Now, the key again is this is the sump pump of the left heart. If you look at the picture, the only place that this device can sump the blood from is the LV. So what that means is that we have to be able to get the blood from the RV through the lungs and to the LV. Because this device functions the way it does as an Archimedes screw and a microaxial flow pump, it is preload dependent. Again, like a sump pump, it can only suck the blood that's there. So the Impella can only help to the aspect of the blood that's in the left ventricle. This means there can be two reasons why there's no blood in the left ventricle. One, the patient can be dry. The patient can be bleeding, whatever the scenario. If there's no blood in the left ventricle, it can't go forward. And that's simple. If the patient is dry, you give them volume in the left ventricle, the Impella pumps it forward. However, the other concern, and hopefully that will become a constant through the remainder of this talk, is the idea of right heart must work. If the RV is failing and cannot get any blood to the left ventricle, your Impella CP cannot help you. So that's the critical things. The patient has to have enough volume in their system overall, and you have to have a functional right heart. The other thing about the device is that it is afterload sensitive. The higher the pressure in the aorta, the more resistance there is for the device to pump blood forward. So high SVR leads to less flow. One of my favorite ways to conceptualize this, and maybe because my background is engineering, but I think in terms of engineering principles, and I think about Ohm's law, or voltage equals current times resistance, V equals IR, and turns out for the body, that's similar, but it's MAP equals cardiac output times SVR. And what I can tell you is that I firmly believe the body, when it comes to cardiogenic shock, cardiac output is more important than SVR. The patient can have the same map, but it's far better to achieve that with a low SVR and a high cardiac output than it is to have the other option of having a high SVR and a low cardiac output, but the same map. And so that's one of the things to consider when you have an Impella in place. Having the blood pressure be in the appropriate range, but not too high, will actually benefit the device to flow more forward and provide what the body really wants, which is forward flow. When we talk about how do we control the device, the key is similar. Because it's preload dependent and afterload sensitive, you're not actually choosing flow. You're choosing a P level. A P level is the performance level. It corresponds to the revolutions per minute that the device is spinning at. And then based on preload conditions and afterload conditions, you get an approximate flow. But again, you're setting a P level, which is really setting RPMs. The key with this is if you'd see at P9, we can achieve about 3.5 liters of flow. So that's pretty good. That's going to be quite supportive for most patients. Many patients, barring the very, very large patients, 3.5 liters of flow is probably going to be enough to support that patient's forward flow. And they don't have to have a ton of LV native contribution. The thing about this is that requires, as you'll note, 46,000 revolutions per minute. And this is why we get into some of the challenges of dealing with the device. And it's because those high RPMs can lead to some blood destruction in the form of causing hemolysis, leading to some anemia and thrombocytopenia. So with every Impella CP comes an automated Impella controller. I kind of think of this as like our interface for both monitoring and controlling the device. When you look at this device, some of the pro tips are, turns out if you look at the top left of the screen, it's going to tell you the exact device you have. In case you're not sure which Impella you've got, it tells you in the top left. The other things that it tells you is it tells you the P level, that's over on the right side, and this is also how you would adjust that P level up and down. This is also where the purge fluid, which I'll discuss in a moment, is controlled from and maintained from. And it additionally provides us some insight into both the function of the device and its location. It provides us via fiber optic sensors an indication of an LV waveform and an aortic waveform. It also shows us the motor current, which is also helpful for the safety of the device. And it additionally shows what our flow we're getting. And as you can see on the bottom right, it actually calculates the cardiac power output for us, which I alluded to before as being one of the top priorities in cardiogenic shock is increasing the cardiac power output. I mentioned the purge, and so the purge I bring up only because it's something you need to be aware of. The purge is essentially a continuous flow of fluid. At this point, the fluid is almost universally dextrose with a small amount of bicarb. This is continuously flowing through the device and being dripped onto the metallic part that's actually spinning. The purpose of this is to protect the impeller and avoid blood contacting the metallic surfaces. Again, this used to contain heparin, but it no longer does. So this purge protects the Impella. It is not meant to do anything specifically for the patient. It's to protect the device. And it's going to be very important that you ensure that the purge remains continuous and that there's no alarms associated with it perioperatively, as purge-related issues can lead to pump failure. So if I could give you one slide of how to manage the Impella, I think the keys would be the most common issue you're going to have is suction or low flow. These are alarms that you'll see on that automated controller. One of the common things you should rule out is malposition. Turns out if the Impella is bumping into the wall of the ventricle, that's going to inhibit it from having any flow. That's easily checked with the AIC as well as with echo. The other thing you need to be concerned about is that preload. The recommendation is that the CVP should be greater than 10 for a left-sided device. If it's below 10, that may represent that you don't have enough volume in the system, and that's leading to your suction alarm. However, the much more concerning thing, and I know I'm a broken record, but it could be right heart failure, and you need to check for that. Additional things are hemolysis. So a hemolysis can come when there's malposition. It can also come when you continue to run the device at very high P levels. The goal is to run the device at the lowest P level that provides adequate support for the patient and to monitor for any evidence of hemolysis so that you can treat it ahead of time. Early indicators of hemolysis may be change in urine color, but also can be picked up via trending hemolysis labs like LDH, haptoglobin, plasma-free hemoglobin. Other things to be aware of, there is a significant risk of ischemia and bleeding, and by that I mean at the femoral arterial site. This is a large bore femoral arterial access, and as you can imagine, if you have major issues with the coronary arteries, you're likely to also have peripheral arterial disease, so that can be a complication. And again, most of it starts with best practices at placement, but it also continues on with close monitoring for ischemia, bleeding, and evaluation for distal perfusion, meaning perfusion to the leg beyond where that catheter is in place and obstructing flow. And then finally, it's still possible to have cardiac arrest when an Impella is in place. They used to always say to drop to P2 prior to performing chest compressions. However, they're changing that now because the thought is perhaps if providing forward flow can be continued, that will be beneficial. But you probably should still drop the P level if suction is also occurring. The other thing, and I'll get to this in a couple slides, is that you might not need to do chest compressions when your patient has an Impella. And the decision to do chest compressions has to be a little bit nuanced. So when we move into, so what's monitoring or what can I expect to find this patient to have? Well, they should have a PA catheter because if you look to the image on the top right, PA catheters with an Impella is associated with a better outcome. Across this is several years of study, and the patients in yellow had an Impella and did not have a pulmonary artery catheter, and the green, they had a pulmonary artery catheter with their Impella, and there's a significant correlation between survival when you have an Impella and a PA catheter versus an Impella without. And again, I think that's because that's what tells us whether the RV is okay or not. Most patients will additionally have an arterial line and a Foley catheter. They may or may not be intubated. Some patients, if they get the Impella up front for their cardiogenic shock, may avoid that slide into pulmonary edema and intubation, but they may or may not be intubated. There should be many laboratory values available for evaluation. Some of these are evaluating how the patient's doing in terms of the progression or regression of their cardiogenic shock, but they will also have labs to evaluate for hemolysis, as well as to make sure there's no bleeding complications and that they're appropriately anticoagulated. They'll additionally have a daily transthoracic echo. This is done to verify the position of the Impella is appropriate each and every day. The key is that the Impella is meant to be 3.5 centimeters into the ventricle. That's 3.5 centimeters to the inlet area from the aortic valve. It's easy to remember. An Impella CP can flow up to 3.5 liters per minute and should be 3.5 centimeters across the aortic valve. Additionally, you should keep in mind that these patients have a large indwelling device sitting in their left ventricle and in their arterial tree. Because of this, these patients will likely be anticoagulated to protect against embolic or thrombotic events associated with having indwelling arterial catheters. So most commonly is heparin, but also can be bivalirudin. In addition, many of these patients will be on dual antiplatelet due to their likely acute MI and stenting PCI that was performed being the indication for them to remain on their antiplatelet therapies. So what does this mean in terms of anesthesia and how do I take care of them? Well, the first thing to consider is what's going to happen to the monitors. So the thing is that when you are putting an Impella in, you are transitioning the patient into some degree from pulsatile flow to the laminar flow that the Impella CP provides. What this means is that as you provide more Impella support and the LV does less work, you will have a transition to laminar flow, meaning the systolic blood pressure will decrease and the diastolic blood pressure will increase. This will decrease the overall pulse pressure. So the thing that we know that's universally still true is that the map is the map. You can reach the point of a pulse pressure of 0. What this means is that the left ventricle is not doing any of the cardiac output. The patient is fully dependent on the Impella. Now, is this good for the patient in general and their ability to recover? Probably not, but the patient may be totally fine and have a flat arterial line, and that is okay as long as they still have to have a pressure on that arterial line. A flat line with a map of 70 is completely fine. But the key with this is it may mean that you cannot use a non-invasive blood pressure cuff. And additionally, that also means you may not be able to use pulse oximetry because pulse oximetry depends upon pulsatility. No pulsatility doesn't mean the patient's not oxygenating or not perfusing, just means the pulse ox can't pick it up. The key though is, and I'll say it for, probably 1,000 more times, the right ventricle must work. So you must have a pulsatile waveform on your pulmonary artery catheter. The key is this is what distinguishes when you need to do chest compressions or when you don't need to. If you have a flat arterial line and the patient's in VT, you may not need to do chest compressions as long as the PA catheter remains pulsatile. The moment your PA catheter becomes non-pulsatile, you must perform chest compressions because the only way the Impella can provide forward flow is if the right heart can get it there. This picture is actually a picture that's a real patient that had an Impella CP. As you can see, the arterial waveform is showing almost no pulsatility, a systolic of 91, diastolic of 88 for a mean of 89. I'd argue they should probably get the pressure down. That's too high of afterload at 89. And then with that, you'll see that where the pulse ox is, it's just reading low perfusion, which I would say maybe not, just can't pick up pulsatility. But what you'll see is the PA catheter does have pulsatility. So in terms of practical tips for when you find out that the patient with an Impella, I don't know, they are now having ischemic bowel and they need an XLAP. So, or whatever it may be, they're having a GI bleed, they need a colonoscopy, you name it, whatever the scenario is, it's probably not going to be with a ton of advance notice. And so what I would highly, highly recommend as the first step is to call the Impella clinical support rep and invite them to join you. The phone number is located directly on all AICs, and that is their whole role is to support. It's also available 24/7 to call for guidance. Beyond that, I would also identify the P level and flow, the position of the Impella at the groin, and also on the echo. Figure out where it is stably and ensure it stays there, or be aware if something changes where that problem is. I'd also make sure to be aware of what's going on with the limb. Is the leg currently perfused well? What's going on with the Foley as an early sign of are there issues with hemolysis? I'd also assess what monitors are in place. Does the patient have the arterial line and the Swan and the Foley already? Are they intubated or not? Discuss the anticoagulation plan with the surgeon. Make sure that the surgeon knows what the anticoagulation status of the patient is and what the plan is in terms of holding or continuing with that. And then plan how to protect the RV. Primarily think about volume status and management, and as I'll discuss on the next slide, the implications for your anesthetic plan. Additionally, have an emergency plan. Make sure that the surgeon, the cardiology team, you and the family all know what the limitations are. Is ECMO an option at your hospital? Is an RP flex, the right-sided Impella, an option if we get into RV trouble? Or is this Impella CP, is this the maximum level of support? Even if it is, that's okay. But I think it's important for the surgeon, cardiology team, and most importantly, patient and family to understand that this by nature is a high-risk procedure and that if something goes wrong, there is no further support options available regarding the heart's function. Additional things to consider. One, well, neuraxial and regional would be nice, but the anticoagulation status is likely prohibitive. I would also be very cautious, even if the anticoagulation is reversed, that the patients may still have thrombocytopenia, and they may have some other kind of, there's a well-established incidence of induced von Willebrand's disease when patients are having laminar flow. That's not specific to Impellas, but just something to consider. Oftentimes neuraxial and regional is not an option, despite the benefits that could have that patient in avoiding the next couple things I'm going to discuss, which is intubation. If the patient's not intubated, be aware, we all know that intubation and positive pressure ventilation is bad for the RV. While it can be beneficial for the LV doesn't really matter right now. It's well supported by the Impella. Because of this, you may need to do things to adjust the P level and basically consider the implications of that positive pressure. Again, not so much for the left ventricle, that's taken care of, but what this may or may not do to an RV that might be struggling. Similarly, if you choose monitored anesthesia care, just be aware of those same things. Hypercarbia and hypoxia leading to increased pulmonary vasoconstriction can be bad for the RV. Also of consideration is the abdominal insufflation, which is carbon dioxide, that they may want to use. While it's a less invasive surgical approach, it can be harmful if that RV is struggling. Other things to consider, positioning. Positioning may be a challenge. Ideally, the patient would remain supine, where you have easy ability to visualize and access the Impella site and make sure that everything's fine and stable there. However, sometimes this is not possible. My recommendation would be that if the patient does need to be turned lateral or any other kind of odd position, that the positioning is done slowly and cautiously, and I'd recommend keeping the Impella groin to be the downside. It tends to have less movement as the patient's being moved. And then finally, a simple thing, but remember, plug in the automated Impella controller. You need that device to maintain its function, and it provides the power for the Impella to continue functioning. It does have a battery, but it will only last for 60 minutes, and you need that for the transport time. So finally, it's coming, the future. So what do I mean by that? I mean, Impellas are going to become more and more apparent. There's already the use of them for planned things like planned high-risk PCI. A patient comes from home, they're not in shock, but they're going to get a procedure in the cath lab. They will place an Impella to do the procedure because it makes the patient safer. Similarly, it's happening in cardiac surgery. We're putting devices in. A patient comes from home with a low EF. The plan is to use an Impella to support them through their cardiac surgery. What it's doing is it's enabling patients that previously were not surgical candidates or not PCI candidates to get therapies that were otherwise closed off due to their low cardiac function. And so similarly, I think it's going to happen. In fact, it already is. Now your patient might have a hip fracture. They have a low EF. They're not in cardiogenic shock, but there's a worry about their ability to tolerate anesthesia and surgery. They'll probably get an Impella placed for the purposes of getting their hip ORIF. Now, this may seem intimidating, but the actual reality is your patient is now safer and better able to get through the procedure they desperately need. Similarly, just published was a recent panel discussion about this very topic, non-cardiac surgery interventions on patients receiving Impella support. And they talked about some patients that had undergone, I think it was several sleeve gastrectomies, a nephrectomy, and a cholecystectomy, where they were not in cardiogenic shock, but they were essentially cardiac cripples who may not have been eligible for their surgery otherwise. So an Impella was placed solely for the purpose of supporting the patient through surgery. They underwent their surgery, and then the Impella was removed afterward. So I think it's definitely coming, and it's going to mean that more patients with Impellas will be receiving care by anesthesia teams that are not cardiac specifically trained. And then finally, there's no question that Impellas are going to become placed in people, and those people are going to leave the hospital. And so my joke, I came up with this myself, but that means that it's going to go from temporary mechanical circulatory support to a long T, many T's of temporary mechanical circulatory support. So they're still going to be temporary, but they're going to be in the body and they're going to be in patients outside the hospital, which means they're going to show up to your hospital needing whatever else they might otherwise need and have this device in place. So I think it's useful to know a little bit about them and how to manage it. So in summary, Impellas now have data and guidelines supporting their use in the very specific area of acute MI cardiogenic shock. But I really think that's just a gateway to their being used broadly with people that have low ejection fraction, high cardiac comorbidities, and that are going to be in need of other procedures that will become safer with this device in place. Also, they are in hospitals without cardiac surgery programs. I firmly believe that every cath lab will have the ability to put in an Impella based on the recent data and guidelines change. So you might encounter one, so be prepared. Remember, it is helping the LV, so you need to help and protect the RV. But you also need to protect the device so it can keep helping the LV. And finally, again, don't be afraid to call for help. This is the 1-800 number for that Impella Clinical Support Center. I assure you, I call them. And well, that's not true. I bother my local reps who I have their cell phone numbers of, but I still would call this number because it's just ask for help. Their whole job is to provide help. It's not to sell the device. It's to make sure that when you've already decided to use the device, that it's used for the best possible outcome for the patient. In conclusion, I would be remiss if I didn't do a little self-promotion, and that's that I'm giving another virtual lecture this very week. It's on Friday at 5 p.m. I didn't choose that time, but that's when it is. It is the New York State Society of Anesthesiologists Committee on Critical Care, and it's actually the inaugural, but aimed to be, quarterly conference on mechanical circulatory support. I'm going to be talking about LV venting in VA ECMO and discussing an actual case that of a patient I took care of at Upstate. So this is going to be a similar topic. It's going to be discussing the use of Impellas just in a different kind of utilization. This is the links. I can put it in the chat once I finish sharing my screen here. And then finally, I just want to say thank you. Thank you for attending. I'm happy. Please reach out if there are any questions. I'll be happy to share my slides. My whole goal is to get more exposure and help more patients. And I think that means making everyone feel comfortable with using these devices. So here's my email, my LinkedIn, my WhatsApp. And then I also, I'm going to do a little more, advertising, and that's for GoMed. GoMed is Global Outreach for Medical Equity and Diversity development, and the website's letsgomed.org. This is a nonprofit that I have formed with a cardiac surgeon, Dr. Farhan Nadeem, and a cardiac surgery PA, Connor Waslanak. And what we do is we essentially take what's otherwise going in the dumpster from hospitals, meaning surplus and expired materials that are expired in the eyes of the FDA in the United States. We will take it, inventory it, store it, and then we are distributing it to anyone who will take it in countries in need, largely sub-Saharan Africa and South America, as well as some areas in the Middle East, and we're branching into Asia as well. So please visit our website, and if your hospital has any things that might be going in the dumpster, we'll be happy to take them off your hands. And with that, I'll conclude and turn it over to Dr. Ellis.
Courtney, thanks so much. And just a reminder for those who weren't here at the beginning, I think you get a sense of the excellent education that we try to offer. We'll be in Grand Cayman at the end of January 2026, as well as 2027. That's our website there, destinationcme.com. Tracy will put that back in the in the chat. It's there also. And I have pre-populated the chat with some questions, but I actually, if folks want to come on camera, show one more slide, please. Yep. This is, we'll be there, nice beach, nice place to be at the end of January, especially if you live up north. So we hope some of you will consider joining us. Some of you certainly have in the past. So if you can stop sharing your screen, please. And I don't know if anyone wants to come on camera, but in the meantime, I put a bunch of questions here just to get things started, but I want to prioritize people who are in the meeting here. Or people can put questions in the chat as well if they want, if you don't want to come on camera.
Let's see. I'm just adding to the chat the link if anyone's interested in that other webinar on Friday I mentioned. And I'm also putting our Let's Go Med website in there for anyone that's interested. Otherwise, I will take a look at the questions that you've put in there. So I think the first one I see there is ever have devices on both the right and left? Yes, that's called bipella. That's where you have a left-sided device, the Impella CP or the 5.5, and you additionally have the RP on the right side. So that is pretty nuanced, can be a little bit challenging to manage, but yes, that's not an uncommon scenario. I think generally, if you're reaching that level, we may not be talking about kind of the regular cath labs that might be in community hospitals. And so you may have more resources at your disposal if you're encountering the bipella patient. I think you also noted what's the lowest P possible. So I didn't go into it, but you actually never run the device below P2 because turns out when you have a fairly large device sitting across the aortic valve, it can create some aortic regurgitation. So you always want to have it on P2 or higher. But really, the answer for what's the lowest P possible is you run it at whatever achieves the goals that you're indicating. So that's avoiding cardiogenic shock. So I follow closely both the lactate, kidney function, liver function, and I use my SWAN to ensure that I have adequate forward flow. And I look at that cardiac power output because that, as I mentioned before, the cardiac power output really is the one that's most tightly tied as an independent predictor to in-house mortality in these types of patients. Um, let's see. I do see another question at the bottom. I'll skip to that one. It says, can I comment on the current use of the 5.5? We are inserting them in combination with ECMO. Yes, I hesitate to say it, but as much as I love the CP, my true love is the 5.5. The 5.5, as its name suggests, can flow 5.5 liters of forward flow. Literally, your left ventricle doesn't have to do anything. The other thing it does is it's placed either directly in the aorta via a graft or the subclavian arteries. It does have to go in the body via a graft, hence why I discussed the fact that it's more apt to be in those cardiac surgery centers. But yes, the 5.5 has a lot of advantages compared to the CP because it's larger. The RPMs are actually lower to achieve higher flow. So there's less hemolysis. It allows the patient to be more up and ambulatory. And that's actually I think that's the gold standard at this point is if you have someone on VA ECMO, you insert a 5.5 and it allows them to liberate from ECMO pretty quickly. And then let's see, I see another question. In a cardiac arrest scenario, can you just look at your flows to see if CPR is even needed? Yes, I think what I'm alluding to is that you just have to, you don't, it's more the idea that if your arterial line is flat, if you have another patient that doesn't have an Impella and their arterial line is flat, you have a problem and that requires CPR. But it's a little more nuanced and you can use other markers. The one thing I draw attention to is that it's oftentimes malignant arrhythmias. And sometimes you actually, if you still have pulsatility on the pulmonary artery catheter and you know that the RV is still able to pump forward flow, you may be able to avoid CPR and just provide, rapid defibrillation. You can provide, some evidence from the Impella itself regarding if you're still flowing. That can be a meaningful thing. I think the point I'm trying to make is that you'll initially probably still have flow from the left side, but at some point, if the RV stops working in whatever this scenario is, shortly behind your kind of quasi-cardiac arrest, if you lose pulsatility and function of the RV, will be the suction events and loss of flow that you'll see for the Impella. Okay, I see another question. What medication for acute right heart failure situation before right-sided Impella can be placed and or to temporize? Well, I think the way I see it is that most patients with these acute MIs, they just statistically end up being large LAD infarcts, more likely to be in cardiogenic shock. And a lot of the RV failure that develops is kind of secondary. And what I really think it's secondary to is that when you get into this cardiogenic shock state, there's lack of forward flow. There rapidly becomes distension of the LV. There becomes mitral regurg, increased left atrial pressure, increased wedge pressure that's seen, and that leads to pulmonary edema. And then once you become hypoxic, now that RV starts to fail against the high pressure load and now with hypoxia developing. So I think my predominant thing is to identify which is actually the problem. It's rare in acute MI to have concomitant dense biventricular failure. It's almost always univentricular to start with, and statistically more likely to be the LV. So I think if the first answer is intervene, meaning get to the cath lab, do the stent, put in the Impella, whatever needs to be done to reverse the left-sided failure before it progresses to right-sided failure. My strong preference is milrinone. I think milrinone's the optimal medication for preventing RV dysfunction, to the point that I will almost empirically start some milrinone in patients with left-sided Impellas just because I'm so obsessed with protecting the right heart. So the answer for me for acute right heart failure is milrinone, but I'll also say I feel really strongly that the answer for RV failure is always diuresis and volume removal. Let's see, I see another comment. I think this is your Dr. Ellis, the patients with aortic stenosis and regurgitation. The answer is, now this is, obviously there are some FDA indications for use that they say, aortic stenosis is not appropriate. I will say if the cardiologist can cross the valve, then an Impella can go in. The only time that it absolutely cannot is a patient with a mechanical aortic valve. You cannot put the device across a mechanical aortic valve. However, I've used it multiple times with both aortic stenosis patients and aortic regurgitation patients. And in both scenarios, if the patient's primary issue is the aortic valve, we are essentially bypassing that. So if the device can be put in, it can provide therapy. Both, obviously, it won't definitively fix aortic regurg or aortic stenosis, but it's a very effective bridging device to get to a definitive therapy, whether that be surgical intervention or TAVI. All right, I see. Can I talk more about placement signal and LV pressure so we see on the face screen? Yes, so the nice thing about the Impella is that it includes sensors. So it gives you both an aortic waveform and an LV waveform. And then what the AIC is doing is it's interpreting those to help ensure that the placement is correct, meaning if it's able to sense a difference between the aortic waveform that will look very much like an arterial line, but again, diminished pulse pressure. And then it will look also very much like an LV signal. And if it can appreciate those two differences, that provides us with some, without echocardiographic imaging, some support and comfort the device is in the proper position. The issue becomes that if you lose, primarily, it's if you lose that aortic waveform, it then will tell you that there may be a placement issue. But really, that's in patients that if it doesn't have that nice aortic pulsatile nature, it does not necessarily mean that the Impella is malpositioned. It's just saying that the algorithm where it's looking for an aortic pulsatility, it's not able to interpret that. So it's not so much that something's definitely wrong, it just can't promise you that it's right. Again, and that's where I would say anytime that there's any concerns, reach out to your clinical support specialist. There are ways too, as I tell people that I work with, there's this thing called Impella Connect. I can actually see the AIC screen of any of the patients with Impellas I'm taking care of from my phone. So I'm able to help guide, even remotely, walk people through what's going on with those waveforms, and is it really a problem, or is it just telling you that it doesn't have the right information to give you the comfort you're looking for.
And she did give her WhatsApp number, everybody.
I did. And then finally, I see, can I comment on infectious risks? Honestly, the infectious risks are quite low because this is in the arterial system. So if you think about it, it's actually venous access because it's a low flow situation that's associated with bloodstream infections. Arterial lines, and this is frankly just a very large arterial line, are not really associated with bloodstream infections. So like anything, it should be placed with sterile technique. But to my knowledge, and personally from my experience, I have not seen any kind of real correlation between the Impella and infection. And it's a leap, but I would say that you probably are less apt to have an infection if you actually have forward flow and are perfusing your tissues adequately.
Well, all right, all right. I want to thank Dr. Maxey-Jones. If anyone wants to come on camera and wave at her and thank her, and she's let us record this. So if it's okay with you, we'll share with the people who signed up for this. We hope that you learned something today. And we do these every so often, but we certainly encourage you to come to Grand Cayman at the end of January. That's Destination cme.com. And with that, we'll let you. I'm here in Chicago, and the light is still out, and I think I may go for a little walk. So thank you all so very much for joining us.
Right. Thank you very much.
Anybody else want to come on screen? Can we see you? Nah, they're shy. How about our people in Erie? We got the whole crew there at dinner. Yeah, there you go.
Yeah, they're all here. Thank you.
That was fabulous that you joined us as a group. Fumi, I see you driving. Be careful. You know. All righty. Well, Albert, my man. Oh my God, Albert, always. Great. Well, thank you all. Have a wonderful evening.